All right. Ooh. So, I kind of have my little resource guide here. And essentially my resource guide, or what I learned everything from, is University of California, San Francisco website. It's essentially it's geared towards healthcare providers. Um, but it can be used, well, the way I used it is to find out what I should be getting from my healthcare providers, what I deserve, and how my hormones should be dosed to me, um, and how my care should look. Because I know a lot of people live in a lot of different states and rules are different, but overall, transgender healthcare is very specific in the way that it um, looks. So, this website, it's called the Center of Excellence for Transgender Health, is geared towards primary care providers. So that they can use this website as a resource and they can say, oh, I have this trans patient that came in, a binary patient that came in, and they talk to me about X, Y, or Z. You can find it on this website. It's so amazing. So, the challenge with it is that you kind of have to be able to decipher medical terminology. So I'm going to try and help do that. So this website is my favorite thing because on the side, it has like table of contents, it has terminology. So providers can look up terminology. They can look up like, oh, my patient is using this language and I don't know what that means, so let me look it up. Wouldn't that be amazing if our primary care providers would do that? They don't. At least mine doesn't. So, there's a gender affirming overview. There's a physical exam. So, like, you have a transgender patient and, you want to know what language to use, or, I have to do this physical exam and I'm going to be, I have to touch certain parts of your body at certain times. I'll let you know, and I'm going to do these things. Could you tell me what language you use for certain parts of your body so that I am using the right language? I've never heard a primary care provider say that to me, but I wish that they would. Um, and so certain things like that. So what I'm going to talk about is there is specific sections on masculinizing and feminizing hormone therapy. So I'm going to hit the masculinizing because I'm pretty sure that the majority of my folks that follow me are trans masculine folks, but I do have information about trans feminine if anyone wants it. I can definitely do that. So, I'm sorry, I'm still have a cold after 2 weeks. So, this is where I got all of my information. So, something that's really important to know, and something that I felt like I got gatekeeped when I first started to look for someone who would prescribe for me, is providers will say, you'll go to your primary care and you say, I want to start hormones. And they say to you, you need to go see an endocrinologist. And that's what happened to me. That is not true. So, unless for some reason you have some like comorbidities. So, comorbidities would be like you are diabetic, you have other like health histories that perhaps, and I'm not talking about mental health histories, and that's something that is really, I want to stress that because I often, as we all know, being trans and having a mental health history gets kind of lumped together as if it's like the same thing. And, you have to have this mental health history to be transgender, and we all know that like some primary care providers will require a diagnosis of gender dysphoria before they will even prescribe. And then we have the wonderful humans that do informed consent, which makes more sense. So, I want to stress that NPs, so nurse practitioners, physician's assistants, PAs, MDs, or DOs. So an MD is a doctor, what you would think is, a doctor. DO is a doctor, but it's doctor of osteopathic medicine. My friend Preston is a DO, and the difference really is the way that they're trained, but they're doctors, they can prescribe. So when you go to your primary care provider and they tell you that, oh, I don't do that, you have to go see an endocrinologist, that is actually not true. I often find, just don't want to do it because they've never done it before, they're not comfortable with it, they don't understand the process. But in any other circumstance, if they have a patient and they came in and say, I have this weird medical thing happening, they're not going to just send you out to someone else. They're going to do research. They're going to look stuff up. Let me talk to my other coworker and see if they've ever come across this weird medical mystery. And then, they can send you to specialists from there. But, if you don't have, what am I trying to say? If you don't have private insurance, a lot of times going to see a specialist is really expensive. And, getting hormones is really expensive, and all of these wonderful things that make it so hard for us to get hormones. If there's anything that I'm not saying or talking about that you want me to talk about, I can. But I want everyone to know that, the information that I have, obviously, I'm a trauma nurse. This isn't what I do on the regular, but it's obviously something that's important to me, and I've done a lot of research about it and the care that I should be receiving, and my friends and other trans queer folks should be getting. So that's why I've done so much research into it, and this website is like the Bible. So what I hear a lot about, first thing is IM versus sub-Q. Is there a difference? So on this website it says essentially no, there's no difference. The only real difference is that IM over time, sometimes you can build up scar tissue in your musculature from keep poking. So subcutaneous can be a less painful route to take long term as well. It builds up less scar tissue over time. So we have a puppy dog visitor. So let's see. Oh, and gels. So you can do gel if you're super not interested in poking yourself with anything sharp. The hard part with that is that you have to do it at a certain time where you're not going to shower, or it's going to be rubbed off on anything. You don't want it to come off on your clothes. You don't want it to come off on someone else that doesn't necessarily want testosterone. So that just makes it a little bit more complicated than doing a quick shot and you're done. You don't have to think about it again. So the first thing is so when you first go to your doctor and they want to take certain labs on you, some providers will take initial levels. So they'll take, and it says right on this website, it's so easy to prescribe hormones. It makes me so sad when people send you off to all these different providers. It's so unnecessary. So you can, what they can do is they'll take sometimes they'll take an estradiol level for transmasculine folks, but they only really do that as needed. They may or may not initially take your total testosterone because, and this is important information, no matter what sex or gender you were assigned at birth, every human being has testosterone and estrogen, regardless. It is not something new. Some people might have a little bit more testosterone or estrogen in their bodies at when at baseline. Like, say, I actually didn't get my, hey buddy, I actually didn't get my testosterone levels checked at baseline, but I'm actually really curious because if I had gotten them checked at baseline, I'm curious if they would be higher than a typical cis woman's, like, normal testosterone level would be. I'm just curious. For for science reasons, I'm curious. But really, based on this, like, if you look at this website, all it really says is baseline. All you have to get is a hemoglobin and hematocrit, which is basically like, which is different for men and for women. So they like to get that baseline marker, and once you start testosterone, that can then increase, which is normal. It's going to increase. For transmasculine. I just want to make sure that that's clear because it's going to be different conversation for transfeminine hormone therapy. So, the way they have this awesome chart, this chart is so good. I'm going to try and show it to you. So good. I don't know if you can see it. I don't know if you can see it. Anyway. Romeo, if I'm saying anything wrong, you gotta help me out. Let's see. 3 months is typical. So you get started on your hormones. You get total testosterone. They'll do sex hormone binding globulin. Science words. They'll sometimes take an albumin, which is protein, and they'll take the hematocrit and hemoglobin again. Your total testosterone, is the one that is those levels that we're talking about. So, like, what are your testosterone levels? Are they within normal range? What the heck does that mean? People say that all the time, and not everyone knows what that means. And when they kind of like wait for their provider to tell them, like, yeah, you're in normal range. What does that mean? So, for transmasculine folks, we want our testosterone levels to be within that of a cisgendered male range, which is such a wide range. So it's usually like 330 to like 1100. So what they'll do is some providers will take a peak level. So they'll take it like if you're weekly shots, so it's a different conversation for biweekly. They don't actually talk ever about this in terms of like doing your shots biweekly. It's a weekly shot. So when I hear people say biweekly, that they do biweekly, I've also often heard that they have a hard time with it because by the time they get to their second week, their hormone levels are dropping so steeply, and then they have to get through that last week before they get their shot again. Even though the shot that they're doing is it's like a double dose. So if I do 0.8 weekly, technically if I did biweekly, I would do 0.8. What did I say? 0.4, and then I would do 0.8. So that's sort of a challenge, but so if you do your peak level, it's going to be like midweek. They're going to take what is your testosterone level at its highest. So say they get your peak level and it's like 1,000. Say it's 1,000. And then if they get your trough level, and your trough level is the lowest level. So when I get my trough level drawn, it's the morning of my shot before I do my shot. So like literally right at the lowest level that my hormones are going to be right before I do my shot. What is my level? My last level was 625, I think, which is like perfect. My trough is 6 something. I'm sure my peak is maybe like 800 something, 900 something. So my levels are right on track, which means that my dosing, which is 0.4 weekly, my dog is playing with his bed right behind me. Excuse me, sir. Excuse me. Play with your toy. So, if you have your trough levels drawn and you're somewhere between like 300 and something and I mean, if your trough levels were drawn and you were like in the 800s or 900s, I would say that they should probably take your peak level because you don't want to be going too high. And honestly, you will probably know, like, you're going to feel. People often say, like, I feel really, like, weak, I feel tired, I feel moody, I feel I'm getting bad sleep, I look like crap, I'm really pale. Like, you will have symptoms often, but the problem is you're not going to know if it's because your levels are too low or they're too high. That's why you have to check them. So really, you're gonna get your initial dosing, and also what I came across. So there's something here. There's a place here, a clinic here, that will always start their patients on 0.5 weekly, which is, if you can imagine like your hormones are going, and all of a sudden someone like slams you with this like brand new like increase in hormone. It might throw you for a loop. And that was something that I was afraid of. I had done a bunch of research before, and I was adamant. Like, I went to Planned Parenthood, and I was like, well, first of all, I wasn't sure about, like, 100,000% sure about going on testosterone, and I was really nervous about, like, the changes, and I was just like, I want this to go slower. I want to feel like I have, like, even though I don't have control over it, I want to feel like I have a little bit more time. So I was very adamant about starting at 0.25, which is typically like the lowest dose. You can go lower, and you can start lower. Like, I know some folks who are like singers and things like that, that they wanted to start lower because they didn't want their vocal cords to stretch out too quickly. So that's also an option. And so technically you start on your level. So for me, I started at 0.25, and then you're supposed to. I did not, because my provider never checked my levels. But this is what's supposed to happen. They're supposed to check you at 3 months, 6 months, and I think it's 12 months. If you get through all of that. So what happens a lot of times, it's like, okay, I did 3 months, and a lot of times your levels are still probably a little bit low, so then you can do a little increase. Typically the rule of thumb is like you should give it, like, for each like dose increase, you should give it at least like 3 or 4 months, because if you are like really, if you're starting a new hormone or new dose, so you increase your dose, and you really only give it a little bit of time, like a month or so, it's really not, I mean, it's not a lot of time, it's not very much. And then, so once you hit your year, if your levels are normal, if your hematocrit, if your testosterone levels are within normal range, so like 330 to 1100, they can go and just check your levels once a year. I'm hearing, like, I get messages from folks all the time about, like, that they have to, like, fight with their provider to increase their dose, because, but I often have to make sure that people are asking their providers, like, what their range is, like, what's your level, what are your levels, because a lot of times providers will agree to start you on your hormones, but they don't know really how to manage them. And what I've had to do is essentially tell my provider, like, gently, I'm not going to do that. So, specific example of that is that I was started on testosterone, and after 7 months, I was still getting my period. And I was like, what the hell? No. So I went to my provider, and I was like, I want to get my levels checked, like, and my one provider was like, oh, well, your levels are probably so low. And she didn't want to take my levels. So then I went to another provider, my primary care provider, who magically decided that she wanted to agree to prescribed my tea. And she checked my levels, and then she said, well, let's start you on progesterone. And so I've heard that providers do this. It is not appropriate care for a transmasculine person. Excuse me, sir. He's eating his bed. Okay. No. No. Come on, big guy. That's one way to fix that. Anyway, so, hey dude, so when a provider tells you that you should try, you just did your shot, like right now? Your ass hurts. Where did you shoot it? So progesterone for a transmasculine person is completely inappropriate. It's completely inappropriate. So progesterone is actually given to trans females, and it's also given to cis women for birth control. It's not appropriate. So imagine giving someone testosterone, then also saying, oh, here's some female hormones for you. It doesn't make any sense. There's no sense. So if for some reason you're like still getting your period after an extended period of time, have your provider check your levels. If they're still low, you can increase your dose. And then give it like 3 or 4 months, because that's what I ended up doing. I switched to 0.4. We saw that my T levels were right on point. And I was just like, she messaged me and she was like, maybe we start this. And I gently said to her, I'm not going to do that. Because I know that that's not appropriate, but providers seem to think like, oh, I'll just give you this because it works for cis women. No, please tell them no. It doesn't make any sense. I've heard people that are started on progesterone with their testosterone, which is just mind-boggling. It boggles the mind. Well, congrats on your shot. I'm sorry your butt hurts. I'm assuming you do IM injections if your booty hurts. So, what else do I want to talk about? There's some things. Does anyone have any questions from the peanut gallery? I mean, estradiol levels. My provider took my estradiol levels after I was on testosterone for 7 months. That made no sense because I was already on testosterone for 7 months. And those are really expensive. Those labs are super expensive, as everyone knows. I mean, I can talk about changes, but I feel like all of you guys probably know all about the changes. Unless you haven't started T yet. I was really nervous before I started testosterone, and I did like crazy amounts of like YouTubing and all of the things. Because I wasn't really sure what I would be cool with and what I wasn't cool with. And turns out that I'm cool with all of it. Let's see here. So, I'm trying to think of like the myths that I've heard about think it's like your liver enzymes. People will talk about your liver enzymes being elevated. There's actually no research on that. There's no research to prove that it increases your liver enzymes. Cardiovascular risks are a little bit higher because if you think about it, like men are, cis men are at higher risk for cardiovascular problems and such. Because they have higher blood pressure and they have higher cholesterol and things like that. So it's definitely something to take into consideration. I actually got my levels checked. Of course, I'm gonna have a brain fart right now. My LDLs and my HDLs, my cholesterol, I had that all checked before I started testosterone and after, because, and also, I also went vegan though, like right in the middle there, so it's not the most accurate, because I went vegan, but, it's super important to just make sure that your cholesterol is, under control, because starting on testosterone can definitely increase your cholesterol. But really, I mean, it is so basic. I can't even stress how basic it is to dose hormones. It's really like, and especially for like if you think about like trans females, a primary care provider can prescribe birth control to a cis woman. If they can prescribe birth control to a cis woman, they can absolutely prescribe birth control to a trans female. So, I don't know why they don't. But people are nervous and they want the letters with the diagnoses and they want all of the gatekeeping. I mean, some people have better experiences than others. Like I know if you live in Boston, Fenway Health is amazing. They were the ones I went to the Boston Trans Health Conference last October, and it was awesome, and it was put on by Family Health, and I was like, God, I wish that I had access to these providers, but I learned a lot. Unfortunately, I'm not a nurse practitioner, so I can't prescribe, but I can give you this information so that you can go to your provider and be like, you're not doing it right. But, you have to do it gently, because obviously you need to get what you need to get, and that's what I do with my providers. I'm just like super gentle about it and just essentially just tell her what to do gently. If you seriously want to, I know, it's awful. I mean, we will be NPs. I know. It's, they do make so much money. I know. It's infuriating. It's like, you're like, I know that I'm here to be, someday we'll be NPs. When are you going back to school? You can be the MP in Toronto, and I'll be the MP here, even though we live like 3 hours from each other, just across the lake in different countries. Yeah, it's super frustrating. It's like the most frustrating part because I remember when even Planned Parenthood, man, like, they're great, but they, they like, they say that they're like friendly and all those things, and they are, but, it's easy for them to say like, oh yeah, we do hormones, we do HRT, we are trained, but they don't necessarily like really know and how to speak to trans folks. And so I went to this conference in Boston. There were probably like 500 providers from all across the country, and I'm sitting here and I'm like, where are all these people? I mean, essentially 500 in the entire country is actually really not a lot. But apparently the year before it was like 100. So things are looking up. But it was really astounding to me because it's simple, very, very like simple language that you think about, or that people don't think about, that they say to their patients. And the way I describe it is just like, you have, someone says something to you, or they talk to you in a certain way, or they use, one word of language, and you just shut down. I know I do. Like, I just shut down. I'm like, you lost me. I'm gone. I don't want to tell you anything anymore. And that sucks. And it sucks to have to be the one to sit there and be like, no, I don't need a prostate exam because I don't have a prostate. No. So, and then having to have that conversation, well, I'm trans. I had an experience, and it wasn't even the provider, it was the tech, and she straight up asked to see my surgical scars and then touched them. Like, what? Like, if someone had breast implants, would you be like, hey, could you lift up your shirt and then give them a squeeze? No, you wouldn't say that because it's so inappropriate. I know. It was really bad. It was so bad. It was like, I literally was, and in that moment, you're like the weak one, right? Like, you're the one who's like, you don't have any power in that moment. So you're like, Like, yes, I'm so proud of my chest and I love it, and I would walk around shirtless all the time if it were totally appropriate, but it's not. And why in the world, like, yeah, I guess you can see, but I actually am a nurse, so I know that that's not your job, so why are you asking to see that? But now I have to be the educator in this moment and tell you how absolutely inappropriate it is that you just asked to see my chest. And she was just like, oh, yeah, it looks so good. Wow, it looks so good. And I'm like, sitting there like, I know that. I love it. Like, I'm the one that gets to live with it. But, like, you don't get to put your finger on my scar. Like, have you never seen a scar before? Why are you touching me with this finger? So, there's that. I actually don't even know if my healthcare provider's ever asked. No, she's never asked my pronouns. I have no idea what pronouns she uses for me. She's never asked, like, my name. Like, yes, my name, I chose my name, and, my name is on my license and all of those things, but, like, no one said to me, like, is this the name that you would like me to use? Is this the name? What pronouns do you use? Are you in a committed monogamous relationship? Like, no one knows how to ask those questions. Or are you in a monogamous relationship? Because then the answer can lead to more questions. No, I'm not. Okay, do you sleep with... The old language was, do you sleep with men, women, or both? Now, of course, that's a little bit blurred, because if you're like a non-binary, lovely human, then, Right? It's exactly the same. And, like, yes, exactly. No, you would not be like, oh, let me see that big burn that you have on your chest and let me touch it. Can I touch your burn that you had on your arm? Can you tell me the story about that? Like, let me tell me about that traumatic incident. No, it was so inappropriate, and I was so scared in the moment to say something. Because I didn't know how to without, like, it was so weird because my immediate response was, like, how do I not come out to be, like, the asshole right now? Like, I don't want to sound like a jerk. But she was the one who was in the wrong. So, I know. But, I don't know. I guess what I wish that a provider would say, like, okay, I have this new person in front of me, and at the very least say, like, okay, that's actually not something I've ever, like, dealt with before, or, but can you tell me the right language to use so I don't use the wrong language? At least in that moment, and then they can do some research later. But, like, yes, that then puts you into the education role again. but at least it gives you more of an opportunity to say, to like fill in the blanks, as opposed to someone just like filling them in for you and being like, oh, you look like a cis male, or you look like whatever they decide. And it's infuriating. I don't know if I've ever had a provider like walk into a room and say to me like, "Hey, what are your pronouns? How would you like me to refer to you in this space with other people? Oh, okay, so I have to do this physical exam. Okay. Oh my God, physical exams. So like I have to do this physical exam. Can you tell me the names for your body parts that you want me to use?" Whew. I would faint if I ever heard a provider say that to me. I'd be like, "Sweet Jesus, I found the golden ticket." Like that doesn't exist, because if someone had said that to me, because you can't just say like, "Oh, well, you identify as a trans male." Like, what if you have different names for your body parts, and they just assume that because you're a trans male that you want to call this one thing. You can't do that. So at least it like leaves it open ended. It leaves it an opportunity for patients to be like, here you go, like here is the information, and then they get to learn. Yeah. Oh yeah. But that's why me and Romeo are, who's a nurse in Toronto, which is like right hop, skip, and a jump over the lake, um, are gonna be NPs, because nurse practitioners can prescribe. And then, wouldn't it be a sweet world? I know. It would be magical. And I really feel like if I now it takes me like 3 years to get my MP, so you're gonna have to wait. But if I can do that, at least I feel like if I could get my hands in a little bit, I'd be able to like be in an office or be in a setting that I could then teach the other providers around me. Um, and maybe at that point I'd have some facial hair. I don't know what my facial hair is doing. It's like taking a vacation, and it's all on my legs. So, yeah. I mean, yeah, and that's what I'm trying to do, because unfortunately, as a nurse, you can only really do so much, right? Like, I can give you this information. I can't diagnose anything, I can't prescribe anything to you, but I can tell you the information so that you can go to your provider and say, "Guess what I learned?" Or you can play stupid and be like, "I don't know. I mean, my friend showed me this thing, and can you maybe take a look at it? Have you seen it?" And see what they do. Um, but at least the best really that I can do right now is kind of what I'm trying to do at my hospital, which is join a lot of committees. And I think I might have overdone it. There's a committee called Thrive, which is actually geared towards trans health at the hospital. There's a committee, Cultural Diversity and Inclusion Committee, which I'm on. I just became the chair of my unit council on my unit, which is kind of good, because then if I become the diversity champion on my unit, then I have a little bit more power. So it's just kind of like little things and like people that I work with. Now, I work in trauma, so it's not like we work directly with the trans community, but if they get to know me and I can take those opportunities to educate a little bit, then that's what I can do right now. So, because nursing is really about educating, right? It's like that's what we do. We educate families. Providers come in, they dump a lot of medical terminology, and then we walk in behind them and we break it apart. Um, so that's kind of what I can do right now, and most other trans nurses. Um, but eventually, are you still in California? I don't even know. I thought you left. So, I don't even know what I was going to say. So that's my shtick, and I'm sticking to it. I really highly suggest this website. There is a section. Oh my gosh, there are so many sections in here. Cardiovascular, diabetes, bone health, and this is all trans related. This is not like anyone else. We get our own website. Testicular pain, silicone filler, fertility options, breast cancer, and it says trans women, breast cancer, trans men, because even after top surgery, you're still at risk. Don't forget about that. Cervical cancer, ovarian cancer, mental health, post-op stuff, vaginoplasty, phalloplasty, hysterectomy, binding, hair removal, follicle. It's just so good. I love it. I wish I could be a part of this with these people. And also the other thing, so there is not a lot. I was talking to a new doctor that I met recently, and she's amazing. She's a queer woman, and she is doing a fellowship at the hospital I'm at, and she's going to do research on long-term effects of hormone therapy. And it's so interesting because I was saying to her, I was like, I just feel like I've done so much research on the hospital databases, the really nerdy ones, and I can't find, there's nothing on the long-term effects of hormone therapy. And she was actually saying that underground right now it's exploding. So I'm really curious to see what's going to happen in 10 years from now. What they're going to find, or if they're going to even find anything. Are you going to find anything? I don't know. But I'm really curious, and I'm happy to hear that it's an exploding. It should be, really, the way things are changing, the way folks are, I know, the way folks are coming out, and we're not going to talk politics, but things are, culturally, I feel like things are shifting, and it's becoming, the way I feel about it is when I came out as a lesbian when I was 13, and what a big deal that was. I feel like that's the way it is for trans people now. And to come out as lesbian or gay, is people don't they don't even care anymore. It's just okay. But the way I felt coming out as trans is the way I felt coming out as a lesbian way back in the day. So things are changing. So I'm curious to see how, the younger generation that are figuring this out and having exposure to trans folks way earlier in their life than I ever did, how that's going to affect everything in the science nerd. So I think I've posted this before, but I can post a link. I'm gonna put this very thrilling live that I'm making on my YouTube, and I'll just always start putting in my YouTube so other folks can watch it, if it's helpful. And I can always talk about feminizing therapy. It's really also not a challenging thing to break down. And if you ever want to just hand this to your provider and say, here you go, don't send me to an endocrinologist. You might have to go to an endocrinologist, if you have other past medical history where they're just not really sure how this is how this medication will react, because sometimes that's true. Sometimes there are medications that might react to a new hormone. If you have any thyroid issues, hypo or hyper or something, or you're diabetic or something like that, you might need to go to an endocrinologist. That might not be a lie. They're not always lying. I don't want to completely throw doctors under the bus. I enjoy them. But I've had a lot of, as I'm sure everyone that's watching has had, I've had really bad experiences to make me very, very, very cautious. And it's not just doctors, PAs or NPs, like, underexposure or no exposure or ignorance is ignorance. It does not judge. What else was I thinking about? I think I talked about dosing. I started on 0.25 and now I'm on 0.4. People do start on 0.5. That's a lot. But some folks... And another thing that's super important, I just want to say this and I forgot to say this. So, what's a good dosing for me at 0.4 might be super low for someone else or super high for someone else. There's no, like, perfect dose. So, like, if you are on 0.25 and that is your sweet spot and that is what puts you in that normal range, so like that 350 to 1100, that's your sweet spot. Don't feel like because other folks are on 0.5 that you're not, like, gonna get there as faster, or you're not going to progress and, like, get all of the things that you want in that time frame, because it doesn't have to do with the dose that you're taking, it's your level. So if your levels are within that of a cisgender male and they're consistently there, you're going to get there just as quickly or as slowly as someone who might be on 0.5. That's just their sweet spot. 0.4 is my sweet spot. Someone else's sweet spot could be like 0.15. And it's hard to know why. Like, you're not really going to know why. Like, everyone's body's super different, and you just have to, like, try and remember that, because I think it's really hard, and I think people will be like, my dose is too low, my dose is too low, because they think that there's that, like, goal of 0.5, like, as if 0.5 is, like, the epitome, like, what you're supposed to get to. That's not true. Like, if I went on 0.5, I'm sure my levels would go through the roof, and I would be a hormonal disaster. So that's my sweet spot. Someone else's sweet spot could be lower or could be much higher. As long as your levels are within that range, or your peak or your trough are within that range, because they're both supposed to be within that range, but your peak is going to be, like, towards the high end, and your trough, your low level, so your trough is your lowest level, is going to be down towards the bottom. My trough was 625 or 650 or something like that. So I feel like that's often, like, people are like, oh, I'm only on this dose and I really want to get to this dose, but that might not be the dose for you, and that's okay. Like, and you're not, like, that person who's on 0.5 isn't going to get anything any faster than you're going to. You're both within normal range. Like, if both of your levels are within normal range for your body, that's it. Like, that's all that needs to happen. So, I just want to stress that, because I feel like people often get really, like, in their head about that, about, like, getting to that 0.5. I know that's, like, the magical number for some reason, but it doesn't need to be at all. So you just want to get yourself to a point where you're, like, comfortable and you're not, like, feeling like crap, and having all of those awesome, just totally awesome, like, second puberty, 12 to 15-year-old boy feels. The acne is real. It's real life. But, my voice didn't really drop until, maybe, like, 4 or 5 months, and I got hair all over my legs, just all over my legs, and, like, not much on my face. It's, like, blonde. It's, like, translucent at this point. But, for someone else, they might have, like, a full beard by now, and I'm almost 11 months on T. They can have a full beard by now and have, like, no hair on their legs. And, really, honestly, you just, like, look. Sometimes you can look to, like, if you have any male, cis male folks in your life to, like, kind of see. But at the same time, like, My dad's a grown-ass man. I know he's hairy. At some point, I'll be hairy. So kind of hard to know, but like you'll get there. You don't have to feel like you're someone's progressing faster than you just because they have a beard on their face and maybe they've been on T like long or less time than you have. That's just the way their body's like handling it. It's just doing it. Just your body doing its thing. I think that's all I have to say. Unless people have questions, and you can message me or write it on my page or something. I hope that made sense and was clear, because I think I went on some tangents. So yeah, that's all I have to say. I will let me know if, like what you want me to talk about next week, or maybe I'll do them every other week. Someone had just asked me to talk about this, so I did. But if you have anything else you want me to talk about, I will totally do that.